Evening, everyone. We are going to continue with heart failure and cardiology. Um, it's defined as a clinical syndrome which has signs and symptoms of fluid overload, decreased cardiac output. So, what are signs and symptoms of fluid overload? Patient may experience dyspnea, they may experience orthopnea or dyspnea on laying flat. They may have edema in their extremities. They may have crackles bilateral in their lungs. They may have a jugular venous distension. Hepatojugular reflux may be positive. Decreased cardiac output signs. Patient feels tired, weak, has low blood pressure, or has syncope episodes, etc. Now, remember, diagnosis is clinical, but we use echocardiogram to uh, differentiate what type of heart failure patient is experiencing. In any case, it results from structure or functional impairment of either contractility or diastole, or the relaxation, contraction or relaxation is affected from the heart. Now, now we have three categories of classification or heart failure. Uh, First is reduced ejection fraction with ejection fraction less than 40%. We also call this systolic dysfunction. In this case, the heart cannot pump. A heart failure with mildly reduced ejection fraction, which is 40 to 49% of left ventricular ejection fraction. In this case, it's intermediate. It's not fully full-on systolic dysfunction or not diastolic dysfunction, but it is heart failure still. And finally, we have heart failure with preserved ejection fraction. In this case, left ventricular ejection fraction is more than 50%. We call this diastolic dysfunction, or the heart cannot relax properly. Now, key symptoms, you would see symptoms of fluid overload and or low cardiac output, fluid overload, orthopnea, PND, or paroxysmal nocturnal dyspnea, bilateral crackles, jugular venous distension, peripheral edema, especially in the legs or ankles. Weight gain, they may gain weight up to 1 to 1.5 kilos per day. Low cardiac output signs or symptoms, it's the dyspnea on exertion, fatigue, weakness, exercise tolerance getting impaired, extremities appearing cool or to the touch, and syncope. Now, heart failure with reduced ejection fraction. Most common causes include coronary artery disease, like an ischemic event or acute coronary syndrome. Hypertension is a risk factor for developing it. Valvular disease like aortic stenosis, mitral regurgitation, these can cause heart failure with reduced ejection fraction, where the systolic function is affected. Heart cannot pump properly. Cardiomyopathies like dilated cardiomyopathy, viral peripartum Takotsubo. In this case, ejection fraction is also reduced, so it's heart failure with reduced ejection fraction. Some arrhythmias like atrial fibrillation, where the ventricular rate is rapid, this causes reduced ejection fraction. Reserved ejection fraction, this is more of the heart failure you see in patients with hypertension of long duration. Most commonly, it's caused by hypertension. Hypertension is the culprit in most cases. Even up to 70% of cases may be attributed to hypertension. Atrial fibrillation, it can also cause preserved ejection fraction heart failure. Diabetes, um, it can cause diastolic dysfunction or heart failure with preserved ejection fraction. Obesity, now, obesity is a risk factor for heart failure. Patients who are obese, they usually have chronic overload or chronic strain on the heart, and their heart has to pump harder compared to someone of the same height and weight who, sorry, not weight, same height, but low weight. And patients with restrictive diseases such as amyloidosis, sarcoidosis, etc., they develop heart failure with preserved ejection fraction. Previously, we used to say left ventricular dysfunction, right ventricular dysfunction, but nowadays that terminology is not used because right ventricular dysfunction is rare unless it happens as part of core pulmonal or COPD. such as in COPD and left ventricular dysfunction. By the time you notice it clinically, patient already has right ventricular symptoms. So they overlap a lot. That's why we are now using these new terms, not new, these terms, preserved ejection fraction uh, or reduced ejection fraction. Preserved ejection fraction has different treatment. Reduced ejection fraction has different treatment. Previously, right ventricular heart failure, left ventricular heart failure, the treatment for those cases, we do not determine by which side is affected. Treatment is on ejection fraction of the left ventricle. How much is the left ventricle able to pump blood? Now, for the diagnosis, we have to do two things. First, clinically diagnose or suspect patient with heart failure. Look for signs of fluid overload or in low cardiac output. If they have the typical signs, you can say they may have heart failure. We confirm the diagnosis with testing. So BNP, this is the test that includes heart failure or excludes it. If it is positive, it means that patient has strain on their ventricles, patient has heart failure. If it is negative, it has a very good negative predictive value. If it's negative, heart failure basically, or normal heart failure is excluded as the cause of patient symptoms. We do echo to see the left ventricle ejection fraction. It helps in determining which type of which type of heart failure patient has. And we can also look for etiologies, like if there is a small portion of the myocardium that's not contracting with the rest, etc. ECG we can do to identify arrhythmias if we suspect it, ischemias, left ventricular hypertrophy, and we do troponins to rule out acute MI as cause, because like we said, coronary artery disease is a common cause of heart failure. Now, sometimes patient would come in with acute decompensation of their chronic heart failure or their heart failure. In that case, we have 5 goals to do. First is to identify the cause or the factor that precipitated it and treat that. Second goal is to make sure patient is euvolemic. We try to go aggressive with diuresis, but we have to make sure that we are not causing dehydration or hypovolemia. We have to manage or optimize the perfusion to the organs. Blood pressure should remain controlled well. And we do guideline directed medical therapy once they are stable. Finally, patient is educated and plan for transitioning to community is discussed with patient. All right. Now, if someone comes with acute symptoms, first priority is, are they in distress? Do they have respiratory distress? Are they desatting or desaturating? How is their oxygen saturation doing? Are they low on oxygen? Yes, start them on oxygen. If you think oxygen is not enough, you can do CPAP or continuous positive airway pressure. Protect the airways. Look for causes that could obstruct the airways. Make sure you're giving them oxygen before you start them on diuretics. Second thing, IV diuretics. We go aggressive with furosemide. We start high dose, sometimes 80 milligrams per dose. And what furosemide does, it reduces the congestion or the fluid overload, and it can improve oxygenation, but it will take a while or a few days to a week. That's why we are going to give them oxygen if they have distress or their saturation is coming down. For asymptomatic heart failure, we do not use IV diuretics. Now, some medications that we use in acute heart failure and what MCC wants us to know about them. Vasodilators like nitroprusside, if they have hypertension plus pulmonary edema, they will not give you pulmonary edema. They will say patient has bilateral coarse crackles. So think of pulmonary edema if bilateral crackles are present in a patient who is old with hypertension that's poorly controlled, or someone who is obese and has sleep apnea, and they have bilateral crackles. Think of pulmonary edema. If patient has hypertension and pulmonary edema, We use vasodilators such as nitroprusside. Routinely, it's not used. Routine is, again, we go with furosemide or diuretics. Inotropes, we use it in cardiogenic shock only. So for MCCQE1, remember, inotropes do not provide long-term mortality benefit. They are to revive the patient from getting into shock or their shock getting worse or causing end organ damage. IV morphine was previously used. Nowadays, it's avoided because it worsens the mortality rates. It's not beneficial for patients with heart failures. Now, heart failure with reduced ejection fraction, four treatment options, four pillars of treatment: beta blockers, ACE inhibitor, angiotensin receptor blockers, angiotensin receptor nortriptyline inhibitors. Third option, mineralocorticoid receptor antagonist. Fourth is SGLT2 inhibitors. Now, beta blockers, they reduce mortality. ACE inhibitors, ARBs, ARNIs, they also reduce mortality. Mineralocorticoids, they reduce mortality. SGLT2, they reduce mortality because they inhibit remodeling or they slow down remodeling. Other medications that we use in heart failure, like furosemide, digoxin, etc. Sorry, they do not reduce mortality, but they are good for symptomatic control. Now, the medications in these groups, ARNI, angiotensin receptor nortriptyline inhibitor. Sacubitril is a nortriptyline inhibitor, and valsartan, we all know it's ARB. For MCCQE, remember, this combination is preferred over ACE inhibitor or ARB alone, unless there is a contraindication. SGLT2 inhibitors, they are medications that bring down sugars or diabetes. They are used in diabetes, but they have mortality benefits in heart failure too. So we can use them even if patient doesn't have diabetes. Dapagliflozin, empagliflozin, these are medications that we start in hospital anytime during their course of heart failure management. MRA or mineralocorticoid receptor antagonists, spironolactone, eplerenone. We use them if they have GFR more than 30, but we have to monitor their potassium and creatinine since they can cause hyperkalemia. Beta blockers, carvedilol, bisoprolol, these are medications that reduce the heart rate and help with mortality in heart failures. We do not use them during shock or in cardiogenic shock or patients with acute cardiogenic shock-like symptoms or their blood pressure low. Other than that, we use it in heart failure to reduce mortality. Now, SGLT2 inhibitors, they're medication used for diabetes. But MCCQE1, remember, you can start them anytime during your hospitalization if patient is hospitalized for heart failure. They're beneficial for both reserved and reduced and preserved ejection fraction. Benefit is present despite diabetic or non-diabetic status. Only thing is to be remember that if GFR is less than 20 ml per minute, if they have had DKA or if they are NPO or non-per-oral, do not use them. This can, they are contraindicated in these three cases. Other than this, you can start them. For MCC questions, if heart failure reduced ejection with reduced ejection fraction patient, SGLT2 is almost always recommended. There are some contraindications to it, which are these. Other than these, there are some other contraindications: patient with history of bladder cancer or patients who have recurrent UTIs, etc. They also are not good candidates for SGLT2, but you can still consider it for someone with recurrent UTIs or yeast infections. But these are absolute contraindication. In these three cases, you don't use it at all. Now, coming to heart failure with preserved ejection fraction, the key difference with reduced ejection fraction is that we don't get mortality benefit from using medications here. So our goal is to treat the underlying conditions, hypertension, atrial fibrillation, diabetes. We use diuretics for when they get symptomatic. SGLT2 inhibitors here have benefit. If they have atrial fibrillation, our goal is to control the rhythm. We use amiodarone. Blood pressure, we keep it normal or in the ideal status between 90 to 130 or 135, depending on patient's comorbidities. Normal blood pressure, it stops or lowers the progression of left ventricle remodeling. Now, we have some criteria for heart failure diagnosis. Um, Heart failure with reserved ejection fraction is diagnosed if left ventricular function is more than 50%. There is high filling pressures of the ventricles. If it identifies any structural abnormalities like enlargement of left atrium or left ventricle hypertrophy. Chronic heart failure, patients may have heart failure, and once their acute decompensation is resolved, they may not be symptomatic at rest, but they would get symptomatic on exertion. So patients who are chronic HF patients, we do echocardiograms for them repeatedly to see if there is any improvement in their ejection fraction or if there is any worsening. That's what would decide our uh, management plan. Regularly, we check troponin and BNP. They are good prognostic markers. Troponins, sometimes with heart failure, patients have shortness of breath and they may not think that their new shortness of breath or worsening of shortness of breath is due to an acute STEMI, and that's why we are going to do troponins and BNP on regular basis. Electrolytes in renal function should be monitored because medications that we use for heart failure, ACE inhibitors, ARBs, MRAs, they can cause hyperkalemia, hypokalemia, hyponatremia, etc. Monitoring of their weight is important. Ask them to report any weight gain of more than 2 pounds, which can indicate that patient is retaining fluids. They are not excreting fluids. Sodium and fluid, it should be restricted in patients with heart failure. From fluid should be from 1.5 to 2 liters, and sodium, they should be advised to have a low sodium diet. Medication is very important, and most patients who get admitted with heart failure and readmitted with heart failure is usually because of stopping their dietary restrictions or stopping their medications. That's why you have to uh, be adamant with patient and ask repeatedly, let them know that they need to take the medication, they need to stick to their dietary restrictions, otherwise they can start feeling they can become symptomatic again. Now, for MCCQE1, remember, use this method. First is to what type of heart failure patient has based on clinical findings, and then echo if given. And if it is acute or if it is a stable, if it's a patient with chronic stable heart failure. Step 2 is identify its equity. Is it stable, chronic, or is it acute decompensation? Patient with long-standing heart failure suddenly becomes symptomatic at rest or symptomatic with minimal exertion. This means acute decompensation or acute worsening of the chronic heart failure. Step 3, identify their hemodynamic situation. Are they euvolemic? Are they congested? Or are they hypoperfused? Now, in congestion, you would see symptoms of fluid overload, jugular venous distension, bilateral crackles, ankle edema, etc. Hypoperfusion, you may see their blood pressure low or their skin or mucous membranes, they appear dry. Remember, treatment depends on patient's clinical status and not just the ejection fraction. If their clinical status shows that they are in fluid overload, even if they have preserved ejection fraction, you will start them on furosemide and give them medications to help with the heart failure. Now, some common curveballs that MCCQE one has is that they will give you low blood pressure and a full picture of acute decompensated heart failure. And they want you to focus on giving patient inotropes to bring their blood pressure up before you start giving them fluids or diuretics. You cannot give them fluids, obviously, because they are already overloaded. But before starting diuretics, they want you to give them inotropes, stabilize them first, and then go for diuretics. Now, if there is hypotension given, do not start diuretics. Stabilize patient first, then you can go for diuretics. Morphine is sometimes mentioned to be used. Do not pick morphine for heart failure. It's avoided. It worsens mortality. Vasodilators, sometimes they seem like a good option, but if there is no clear indication to use them, don't pick them as your choice of MCCQ E1 MCQs. Now, this table is for quick reference if anyone wants to quickly decide what to do. Look at clinical status. Patient is dyspneic plus hypoxic. Their saturation is low. Start oxygen, then IV diuretics. Patient has shock or hypertensive shock. Inotropes, assess fluid level, and then mechanical support if needed. Patient with chronic stable heart failure with reduced ejection fraction. All four pillars. So you start stepwise ACE inhibitors or ARB, and then you add another medication and a third and a fourth. You go by like this. Stable heart failure with preserved ejection fraction, you treat risk factors. You can give them SGLT2 inhibitors. They have benefit in mortality or reducing mortality. The other medications, they, like we discussed, they do not provide more benefit for these patients. So treat their cause or risk factors and start them on SGLT2 inhibitors. All right. I hope it makes it clear for everyone. Now we will start with the